Chair for the Education and I'm Natasha Corbin, the Chair for the Education and Membership Committee. And I'm quite pleased that so many of you were able to schedule some time this evening to attend this event. I know we're experiencing some really bad weather, so it's a pleasure. And we really want to welcome you to be here today. Today, you're going to hear a little more about the devastating impact that COVID-19 has had on our heart health. Today, Dr. Kenneth Connell, he will speak on this new NCD risk. And I know that his talk will be very informative and you'll be able to go away with a lot of useful information. But just before we start, I would like to ask Ms. Alicia Granham, this is the secretary for our committee, to lead us by a word of prayer. And that would and she will follow, and then Ms. Carrie Ann Hines will follow by giving an introduction to Dr. Connell. And from there, you would hear a little more about this event, a little more about Dr. Connell's presentation. So Alicia, over to you.
Good night, everyone. Thank you for joining us on this rainy night. About to pray. Father Lord, thank you for bringing us together once again as a credit union and its members and also our visitors for this informative session that we're about to hear from Dr. Connell. I pray that the knowledge imparted by Dr. Connell will serve us in the coming months and years as we try to live in this COVID environment. Father Lord, I also ask that you will bless the credit union, Lord, and the work of its members and all those on the committee and its board. In your name, Lord, I pray. Amen.
Thank you so much, Alicia. So Carrie, over to you to introduce Dr. Connell.
Sure. Good evening, everyone. It is my distinct pleasure to introduce this evening's presenter, Dr. Kenneth Connell. Dr. Connell is a consultant internist / hypertension specialist and is a full-time faculty member of the UWI campus. He's Deputy Dean of Internationalization and Recruitment in the Faculty of Medical Sciences and chairs the CAFO campus's Health and Wellness Committee. As a consultant physician at the Queen Elizabeth Hospital, he manages both general internal medicine, inpatient care, and the Resistant Hypertension Clinic. He is the immediate past and inaugural governor of the American College of Physicians, Caribbean chapter. For his outstanding public service, Dr. Connell was awarded the prestigious Principals Award for Excellence in Public Service in 2019. He has published in numerous peer-reviewed journals on hypertension, as well as the PAHO WHO Hearts Program, and is a guideline writer for the WHO 2021 Guideline for the Pharmacological Management of Hypertension in Adults. His professional recognitions include Fellowship of the American College of Physicians, Fellow of the Royal College of Physicians, Fellowship of the American College of Cardiology. On this World Heart Day 2022, it is my pleasure to invite Dr. Kenneth Connell to deliver his presentation entitled COVID-19 and Heart Health, a New NCD Risk.
So thank you very much, Carrie Ann, for your very kind words. And as you read my introduction, I thought that it really does reflect my day of public service, which has been very long today on World Heart Day. What an exciting committee to be part of this afternoon, to join you this afternoon to present this case. And I promised Carrie Ann I was going to give her a joke that I received earlier at another organization. I see that Grace Eiffel was on or is on this call. But when I recognized that there was a clash, because there's so many things happening on World Heart Day, one member of the other organization, which will remain nameless, but is also associated with heart health, asked me, well, when are you going to tell them you're going to cancel your presentation? And I said to them, well, I'm not going to cancel my presentation for two reasons. One, because the UWI family is family, and family comes first. And secondly, some members of the bursary will probably be on this call. And I also know where my paycheck comes from as well. So I'm going to get started with today's presentation. I hope that it constructs in your mind the scene that we are now facing in what I will describe the post-COVID surge. But I also hope that it solidifies in your mind the need for action at a personal level, at a public level, and even consider yourself as a credit union. What can you do to address the emerging pandemic of cardiovascular health? And the title has already been described. So over the next 20 minutes, I'm going to speak on the pandemic and the post-pandemic curves. And I've stated post in italics because we should not be anywhere thinking that we are post the pandemic. And you'll see why. COVID-19's intimate love affair with non-communicable diseases. From its very beginning, we were told that COVID-19's risk factors for poor outcomes include patients living with non-communicable diseases like hypertension, diabetes, obesity, and cancers. So, but we weren't told, for instance, the impact that COVID-19 would have on these NCDs and even on predisposing individuals without NCDs to having NCDs or even independent risk factors for cardiovascular outcome. So it's been kind of an unfair relationship. The assessment of cardiovascular risk post-COVID-19 at a personal and population level, I'll say something about that. And then my challenge to you as an organization, and finally, with some questions. Now, there are some of us who believe that this pandemic was all a hoax. And sometimes when you listen to the rationale behind that, you're almost convinced in thinking so, except many of us know people who have been ill with COVID-19. Many of us know people who have become very ill with COVID-19. And unfortunately, many of us know people who have passed because of COVID-19. There's absolutely no doubt that this pandemic has caused an excess in mortality globally. Even think back to the earlier days of the pandemic, when we were all glued to the news screen, looking at the numbers going up at the side of like CNN, for instance, and seeing data that was horrifying even before it came to our shores here in Barbados. And once, of course, it struck here, then everyone wanted to know, well, is this an imported case? Remember that? That was the catch question for everyone. Another case found, but is it imported? Because it was okay if it was imported, except that if it came from within, we kind of thought there was something happening. And you know the back and forth. I don't have to remind you of the news conferences, whether there's community spread, what is community spread. We became this captivated with COVID and the jargon of pandemics and epidemiology. And we paid close attention to it. I am sure some of us, including myself, were not really watching Channel 8 before the COVID-19 pandemic. We started watching it. But just imagine this, and here's a shot I took of the American College of Cardiology Instagram post. And I admit I'm a social media fanatic, and Kenneth Aline on this call knows that. But the American College of Cardiology stated today, early this morning for World Heart Day, cardiovascular disease is the world's #1 killer. It causes 18.6 million deaths a year. Now imagine this. If you watch the evening news tonight, there's no counter telling you another stroke, another MI, another heart failure death. But these deaths are occurring at an alarming rate every single day, much more than COVID-19. In fact, WHO suggests that every 2 seconds, someone aged 30 to 70 years dies prematurely from heart attack, lung disease, stroke, cancer, or diabetes. Now, let these data sink in. I said at a meeting at a university near you in a faculty board, which is quite alarming. Everyone in this room is going to die from an NCD if we're lucky. Of course, there was silence because everyone thought, what a morbid thing to say. Who wants to die? But let's think about this realistically. Unless we're struck down by lightning, which is going on outside, or knocked down by a car, and there's a lot of reckless driving out there, or die from an infectious disease, the statistics are that we are going to die from an NCD, right? The only thing we're trying to prevent is premature death. And all that we do as doctors, and I know there's some on this call, is try to reduce risk. I like to say to patients, coming to me and getting your blood pressure control does not guarantee you will live to 100. Although some patients kind of want me to say that as well. All it does, it reduces your risk. Like wearing a seatbelt, for instance, reduces your risk of serious damage during a car accident. It doesn't mean you will not be injured. It just means that your risk is a lot lower. So look at this data, or these data, 5.42 million deaths. This is over a 2-year period. So maybe 2.7 million a year of COVID-19 deaths. This is alarming. I mean, this is something we should be concerned about. But think about it. Look at the amount of people who are dying from NCDs every single year. So let that number sink in. All right. So moving on to another platform that I was on recently, talking about NCDs. This is Twitter. Those of you who are not into social media, please forgive me. So a day ago, I tweeted on Twitter. It sounds like a whole new language. I tweeted on Twitter. It's time to refocus our efforts on cardiovascular health in the post-pandemic surges. Solidarity sign. Obviously, I was targeting 2 individuals. One is our Prime Minister, Myanmar Mortley, and the second was the director of the Pan American Health Association, the Barbados and the Eastern Caribbean. And as expected, he responded and said, well, no doubt, and I want you to pay close attention to this, no doubt COVID-19 is the most visible pandemic in our lifetime, but it is not the deadliest. And do not convince yourself that we've just been through the worst, the deadliest pandemic possible. It isn't. It is not the most preventable either, despite vaccination, wearing your mask, social distancing, wearing or not wearing your mask, hand sanitizing. It's not the most preventable. During COVID-19, and this is an interesting point that he closes with, 5 times more people have died at a younger age, so premature death, due to heart attacks and strokes than from COVID-19 at its worst. We're not talking about Omicron or what if it's BA2 or BA4 or whatever subvariant it is. We're talking about when COVID-19 was at its worst, when we watched CNN and saw all these bodies piled up outside because there was no room in a morgue. Imagine cardiovascular disease was claiming 5 times more people dying from heart attacks and strokes. And this is why I said we may be past the pandemic surge or the infectious disease wave, but we are definitely not past the waves that will probably affect our health systems even more. So here in the purple, and I am partial to purple because it's the color of my faculty, you have the first wave, the immediate mortality of COVID-19, people requiring ventilators. We all know that story. Not enough ventilators. Where are we going to put them? We have this purpose-built facility. Now, note carefully, we have a purpose-built facility for an infectious disease pandemic. Do we have a purpose-built facility for the NCD pandemic that we're experiencing? Okay, so you have this first wave occurring. Patients requiring specialist care, not enough doctors, not enough nurses, having to get people in from places like Cuba and Ghana, task shifting, where several members and several colleagues on this call would know how to be shifted from the hospital to other sites. And then everyone thought, oh, these poor doctors at the Harrison Point facility. And then we kind of didn't remember, well, actually, the rest of the NCDs and their presentations, they haven't stopped. So who's dealing with all the heart failures, heart attacks, and strokes? Because people are getting other things than COVID-19, right? That are coming to the hospital, which was meant to be a COVID embargoed kind of area where COVID was not allowed in. At least so we thought, right? So this immediate wave caused a lot of stress. Don't let us not misrepresent it. It was not a minor event. It caused significant reshuffling, rethinking of the healthcare system. You only have to look to the north to see a healthcare system which, in my opinion, was probably fit for current purpose, highly sophisticated, lots of gadgets and equipment, modern medicine. In fact, many of us travel there for our own healthcare because we think it has the best health system in the world, but unable to adjust to a pandemic when it strikes. Think about it. If you had a house, or a home, and you had the most beautifully decorated home, right? You know, you kept it really tight, you had all the latest gadgets and everything, but it wasn't hurricane proof. It doesn't really matter if a hurricane comes, whether you have the latest smart screen television, right? It just means that you're vulnerable, and more vulnerable than the home that doesn't have those equipment, but still has the hurricane straps and is designed to weather storm. It's more likely to survive it. So although we see shock on the faces of many people as we look at the pandemic in the North, it's no surprising. The thing that holds public health together is a strong public health system, and clearly that was lacking. The second wave involved the impact of resource restrictions on urgent non-COVID conditions. I hope to show you later, hopefully, that do not, for instance, think that the only thing that got disrupted was the number of days or the amount of time to spend in the supermarket, or that the hospital continued in a normal fashion. It did not. And it wasn't unique to Barbados either. Several things stopped. So the second wave was a big impact. And these weren't COVID conditions. What about the person who's waiting for surgery for a cancer, for instance? The hospital is only doing emergency surgeries. Then that person has a higher risk of spread, higher risk of complications, and in my own specialty, hypertension. Several patients, as one of my patients said to me, I'm not even driving past Jamet's Lane because from watching the news, in other words, he did his research, from watching the news, it seems like this thing and hypertension just don't mix. So I'm not even driving past the hospital because just in case there's COVID somewhere in there, I'm not coming to clinic. And many patients, for instance, kind of negotiated which tablet they were going to take on which days, or whether they were going to take half the dose of insulin or adjust their medication just out of fear, right? Then there's a third wave, the impact of interrupted care, which is kind of what we just described as well. The fourth wave is really severe, but not discussed a lot or enough. That is a psychological trauma of being in lockdowns or coming out of lockdowns. Look at an interesting behavioral phenomenon that we are now seeing. Okay, so everyone complained, I can't breathe in these masks anymore. The masks have to go. When is the government going to remove the mask restriction? So what happens? The government removes the mask restriction. What do? We continue to wear the mask because we've gotten so accustomed to wearing masks over the last 3 years. And we're not absolutely convinced that it's safe to remove your mask. Think about it. The next time you travel and you're in a room with a lot of people, are you going to be feeling comfortable not wearing your mask? Or are you going to just slip it on just in case, right? So the behavioral change we wanted for COVID is now continuing post-COVID. I certainly can tell you, I probably will not travel ever again in my life without wearing a mask, despite being the head person looking at people oddly when they wore masks on the aircraft, right? So psychic trauma, mental illness, economic injury. I don't have to convince this audience we're a small island developing state with several shifting of resources and several loans, I am told, just to keep our heads afloat. And every year we have to battle with with climate change, which is getting worse every year, and hurricanes and the infrastructure. We are literally vulnerable citizens of a small island developing state. So let's look at these services here that the World Health Organization has reported in 120 countries. The NCD services were disrupted. I actually thought these data were quite credible when I first saw it, but alarming. I mean, I really did not think that 70%, almost 70% of countries had their rehab services either partially disrupted or completely disrupted. Only this week in the Department of Medicine Grand Round, we mentioned the single most intervention possibly in the post-discharge management of patients with any kind of cardiovascular event, heart attack, stroke, heart failure, is cardiac rehab. But these were the first centers around the world to close. In Barbados, there's only one center, the organization that will remain anonymous. But the Heart and Stroke Foundation, for instance, closed their doors very early in the pandemic. because a gym, no one wants to exercise in a mask. These are people who are high risk, both by virtue of living with NCDs and also because of their age. Even if the gym was open, no one would show up, including our nurses, who were all very fearful of being in a space. Hypertension clinic was a near second. And although this suggests that it's just over 50%, in this country, for instance, I know, and even from looking at the presentations to the emergency room in heart failure, which is largely driven by high blood pressure, we kind of sensed that hypertension control rates were falling. Interestingly, even before the pandemic, control rates were falling for different reasons, but the pandemic accelerated it. Look, these people, as I said, weren't even coming near a hospital. Diabetes, same thing. Asthma, the same thing. Palliative care, urgent dental care. One of my colleagues, even in the university, who I know had excruciating pain because of a dental abscess, could not get urgent care. Because of course, all the dentists were like, wait a minute, we don't know anything about this virus. You want us to look into your mouth, where you're going to expose us, and we don't even know about this PCR test. How reliable is it? When should you take it? How am I at risk? No one wanted to see her. In fact, she was given, and I'm putting on my memory here, kind of an at-home kit. Here are the things you should do at home, but just don't come to the office and follow these instructions, and we'll talk you through it over the telephone. So even accessing urgent care was a problem. And percentage of countries have completely or partially disrupted services. If you look at them in various phases, sporadic, phase 2, clusters, you can see that largely hypertension, diabetes, cancer services, they all suffered. I am not absolutely convinced that we have returned to normal, but maybe we should not return to normal. Maybe we should return to something new. And I'm not going to say new normal either. And who are the places who were disrupted? All countries, but especially low-income countries. When you talk about low-income country disruption, it may seem lower as a percentage of countries, but then you might ask yourself, well, what resources they had to start with even before the pandemic. So even knocking off one resource may reflect in 42% kind of thing. So you have to kind of interpret that based on what resources were available before the pandemic. But look, low middle income countries were affected. Upper middle income countries, and I'm no economist, but I'm going to kind of slip Barbados in here, at least for now, according to Standards & Poor's, right? 78%. So this is serious. I mean, this isn't something that countries should have taken lightly. And if you want to ask about how the pandemic, now listen, this isn't happening at Harrison Point. This is happening at your national hospital. All the NCD staff partially reassigned. These are staff that service the outpatient clinics, including the hypertension clinic, the respiratory clinic, the diabetes clinic. They all had to find other roles. They couldn't just say, well, I'm the hypertension nurse. I can't deal with COVID. Everyone had to be reassigned. Some people volunteered, others did not volunteer. Certainly, the junior staff in medicine, the junior doctors who you see every day at the hospital, they were under significant stress because their colleagues were really the foot soldiers at Harrison Point. They weren't featured on national television, but they were the ones who were doing 99% of the work there. And their colleagues at the hospital then had to take up 150% of their work because of the surges occurring at the QEH of NCDs. So staff were reassigned. Hospitalizations were 6 times higher and deaths were 12 times higher in patients for COVID-19 patients was reported in patients with underlying conditions, including cardiovascular disease, type 2 diabetes, and chronic lung disease, according to the United States Center for Disease Control. And here's what I like to call, and I'm quoting here myself, so apologies to the academics on the line. This is not something we should normally do, but I thought it was a cool graph to show you, right? The DePetty and et al. 2020 publication looking at the perfect storm is what we called it. So here is the acute COVID pandemic, which everyone knows because it's all over the news and everyone is hearing about it all the time. You have interruption of hypertension management. So because this was the hypertension paper, we mentioned that, but you could mention interruption of several things. Chronic NCD pandemic not just remains there, but actually gets worse. We were already struggling at our 34% control rate for hypertension in this country. Think about what the pandemic did. And mind you, this isn't easily reversed or even easily treated with a vaccination. This is going to take years of public health education and system changes even to get back to that level. So there was an increased NCD burden or increased hypertension burden, the increased comorbid diseases with COVID-19 then was experienced because you now have a larger percentage of people who are uncontrolled. You then got increased COVID morbidity and mortality, and this worsened the acute pandemic because the increased morbidity, for instance, meant that several beds, not just at Harrison Point, but did you know, for instance, there were many patients admitted to the Queen Elizabeth Hospital with post-COVID, requiring oxygen, or who were no longer infectious, but requiring additional treatments such as dialysis or other interventions requiring hospital stay. So the next part of the presentation, and I'm watching the time, I'm going to describe what heart patients should know about coronavirus. And to be quite honest, that's everyone on this call. Everyone on this call has a heart, and at least it's working during this call. And so therefore, this applies to all of us, right? And this is something that even when I reflect on these presentations, I have to ask myself, are you really doing all of these things? Are you walking the walk, right? All right, so here is a schematic showing a kind of a relationship between the central virus and the heart. We've heard about the inflammation either associated with COVID-19 or even the vaccine, one class of it, increasing the risk of clot formation, thrombosis, and this was well described as well as the formation of these abnormal cardiac rhythms. All these things are bad, so there's nothing in here that's good. Don't look for it because it's not there. Everything in this box is bad. Inflammation of the heart, clot formation, abnormal rhythms, that's not good, okay? And then you have, for instance, with the lungs, cough, fever, dyspnea. These are just fancy terms. So your lungs are not behaving, oxygenating normally either. Now you need a heart. We've all agreed on that. We also need a pair of lungs, not just because Dr. Allen is on. You need a pair of lungs because they help to oxygenate your blood. And remember, these were this paired organs. These were the first organs to really be exposed to the pandemic and the effects of the acute viral illness on the body. All these other inflammatory markers here cause all sorts of problems, including falling of your blood pressure and failure of all of the organs, including the kidneys and the brain, which didn't even have to fail. It could have just been involved in the acute viral illness. Many of us who had COVID-19 experienced so-called brain fog. Some of us are still experiencing some brain fog after COVID-19. And we don't know how long this will last or even exactly what's causing it. But more importantly, and I would say this openly, and you can quote me on this, I'm accustomed to getting in trouble. We're not even measuring it. Where is there a long COVID registry in our country to even track these things? And is tracking these metrics, is that important? I mean, how do we plan our health system for the future if we're not even sure what's at our door now? So here's some patient information that I thought was useful even during the pandemic. Don't ignore the heart signs during COVID-19, but don't ignore them even outside of COVID-19 pandemic, right? So chest pain, especially chest pain in women that everyone always kind of says, oh, you just have a little gas. Get your little gas checked out, okay? Because especially if you have additional risk factors, it may not be gas at all. It could be something a lot more sinister. Remember, heart attack symptoms in women, especially in older women, especially women living with diabetes or people living with diabetes, are not your classic crushing central chest pain. I actually think that description of heart attacks needs to be removed from a lot of our textbooks because, first of all, there's a gender bias. And it then describes women as having atypical chest pain. But if women make up about 50% of the population, then it's really not atypical, right? So we shouldn't probably be describing the classic chest pain. We should just be saying chest pain in men and chest pain in women. And most women will present with these types of pain. Then there's stroke, which I'm still trying to convince the Trinidadian medical students is actually referred to in this country as a Passover, with numbness, weakness, loss of movement of the face, confusion, trouble speaking or understanding. I think the second point is important. Many of us think that sudden onset confusion is all related to low blood sugar. Even though we test it and it's normal, I still see even colleagues trying to push blood sugar or even getting the person to drink a sweetened drink. Acute stroke presents with acute confusion, and you should be very suspicious in people who suddenly are having a conversation with you and all of a sudden start rambling and you're not really sure what they're saying. They're trying to express themselves and you don't understand them. And of course, loss of balance. So these slides are going to be available to you through Carrie Ann or through some member of the education committee. So you're free to get them there as well. For some reason, this hasn't projected very well, but really what it's showing is that how are you coping with postponed procedures? For instance, all of us here who want to see a healthcare provider in COVID-19 had to deal with being rescheduled. So some things that are suggested on the slide are things like negotiating a telephone conversation with your healthcare provider, or even if the facility is available, telemedicine. I mean, half of my clinic right now is telemedicine, and mainly because some patients recognize, hey, this is more convenient for me. All patients can't be seen on telemedicine, but think about it. What if we complained about every single consultation in medicine? Oh, we're not really getting to access the family unit and see what's happening at home. Sometimes on telemedicine, we see too much of what's happening at home, but we want to meet the family, see what are the challenges, the barriers to taking medication. Tell me, is she really not adding salt to her meals, or is she really doing these 2 laps that she claims to be doing or he claims to be doing? So those kind of things were possible with telemedicine. But how will you negotiate the health system so that you kind of get, even in this awkward period, even though things are going back to near normal, so that you can still see or have a conversation with your doctor? Before I close with a personal prescription, I just want to point out to you that I don't place all the blame on patients at all. And I want to repeat that. I don't place the blame on patients. We live in an environment, and we are really the products of the environment that we live in. If we live in an obesogenic environment that caters to obesity, you know, you could have the strongest will. You are going to pull in at one of the yellow and purple buildings at the drive-through window because it's convenient. And if there are about 40 of them lining the South Coast, then the chances are you're going to find it that I'm stuck in traffic, all this traffic. Someone mentioned it here on the call before we started. So all these social determinants, the built infrastructure, access to services, social support, education, housing, all these things play an important role in framing the social determinants of health. And today at a lunchtime meeting, I asked a minister, you know, who I respect what ministers say in these settings because I know that they mean the best when they're saying so, but, or they should mean the best when they're saying so. But there was a comment made that, you know, get out there, get on the trail, get some more exercise in, and eat healthily, and take your medication. I'm not sure she said take your medication, but do all these things that are healthy, because that automatically pushes the responsibility on the population, or should I say the electorate, right? But suppose you don't have green spaces to exercise, or suppose the healthy foods are too expensive to purchase. What are you supposed to do? Go through the supermarket aisle and say, I would love to have these vegetables, but I can't afford it because the cost of living is too high. And so I raised the question of, well, what are the political determinants of health, especially in this post-COVID environment? So what can an organization like the credit union do? Because you aren't kind of escaping the blame either. You have a responsibility as well to your members. Just like you would want to know that, for instance, there's occupational health standards and that no smoking is allowed in the workplace, and you have access to water. And I know this is the case at K-Phil campus, where I'm going to repeat, I work. You have medical support services like the health center, and there is health insurance available. These are recommended by the WHO. But what are you helping your members with in terms of reducing their NCD risk? For instance, is there a facility within the credit union that would allow members of your union to get a blood pressure device, bearing in mind hypertension is the main driver for NCDs, at a reduced cost? Or are you going to lobby for some other health intervention to try to get them reduced rates in something that is healthy? What is your responsibility as a credit union in that respect? So it's not just the government, but I think as institutions or university as well, we all have responsibilities. So to wrap up, here are 10 ways I think you can improve your heart health even pre-COVID. Balance calories, and this is important. Be obsessive about that. Some people can go on your phone and, I don't do it anymore because it's too depressing, but actually counting the number of calories you consume during the day. The Coke is ready to quench my thirst. Is it really? Is it really? Or I'm going to burn off those calories. That's a lot of running to burn off those calories from that one Coke, right? Reaching for a variety of fruits and vegetables, which should be, from the political determinants of health, affordable and accessible, right? To choose whole grain meals, include healthy protein sources, mostly plants and seafood, using liquid non-tropical plant oils, and choosing minimally processed foods. Every one of us on this call a few years ago were probably convinced the main driver to diabetes is actually all the starch that we eat and all the carbohydrates, right? Well, that's wrong. The main driver is actually processed meats. So the main driver of the diabetogenic diet is actually processed meats. That's what we really should be avoiding. And I know the American Heart Association published this about 6 years ago as well. We should subtract added sugars. It says you can't actually subtract sugar for anything. You just have to take the fluid that has no sugar, such as if you're like myself and you drink way too much coffee, I'm cutting down, then just don't add sugar to every cup of coffee. Remember also that coffee is going to cause you to pass a lot of urine, and in this type of climate we're experiencing, will certainly cause dehydration. Cut down on salt. So canned foods that are in oil, here's a tip, usually have a lot less sodium than the ones that are in water. I know some of you are saying that, oh, I thought the oil was not good for you. But a lot more salt is added to canned foods in water preservative because it helps in the preservation of food. Limit alcohol use. The American Heart Association and the American College of Physicians recommend that we should all be having conversations with patients about limiting the healthy use, reducing alcohol consumption. Every time I say this in my office, I kind of get this blank stare from the patient looking at me like, are you serious? We definitely should have a conversation with them about smoking cessation. And I'm going to finish here with Life Essential 8, although I'm not going to go through all 8. I'm going to stick to what I like to call the meat of the matter, or blood pressure. But you can Google the American Heart Association Life's Essential 8, and you'll see all the platforms for all 8 of them. And I can go through them with you. So healthy diet, getting exercise, checking your blood sugar, monitoring your weight, checking your cholesterol, the one I'm going to drill down on, blood pressure, stop smoking. And this one, I think, is an occupational risk hazard for all of us, that is getting an adequate night's sleep, which is now an independent risk factor for cardiovascular disease. We should all be sleeping between 7 to 8 to 9 hours at night. And I know that doesn't happen often. So you should at least know what a normal blood pressure is, what an elevated blood pressure is, and you should take steps. And I know we're out of time, so I'm not going to go through this slide in detail, but I encourage you on a personal level to download Life's Essential 8 and kind of use it. I do it sometimes over lunch. I choose one and think, am I really getting enough physical exercise? Have I done so in the last week? Or am I really just fooling myself that parking the car across the street from the hospital is going to add up to going to the gym for half an hour? I mean, I know it isn't, but I'm trying to make myself, if you're honest with yourself, you'd really look at the Life's Essential 8 and track them. And there's an app for that, of course. The AHA has an app you can track. I'm going to close here on World Heart Day with the theme of World Heart Day. Use heart for every heart. And to show you some sites that from our local colleagues or medical students here, we need strong political commitment to address the social determinants of heart health. I don't know who that statement came from, but I encourage than to write it. And finally, we have a responsibility to create a healthier hearts through the next generation of healthcare providers. And I will end here. Thank you so much for your attention. I wish you a continued heart healthy day or evening on World Heart Day. And I also challenge, this is really a personal challenge to you individually for Life's Essential 8, but also to the credit union. How are you going to construct for your members? How are you going to reduce their NCD risk in whatever little way you may do so? Thank you very much for listening, and I will open here for questions.
The floor is open for questions. Any questions?
We have a question here from C. Ford. I see a hand up.
Yes, sir.
Yes.
You have been told that you have high cholesterol and diabetes.
Right.
And you made a U-turn in your diet where you're going strictly vegetarian. Is that okay?
Right. So the
no
vegetarian,
rice, no flour, nothing like that.
No rice, no flour, but I didn't realize that rice and flour came from animals. But okay, so no rice, no flour. So you're really cutting off some carbs and you're going vegetarian. I get what you're saying. Now, this recommendation, as you can see, coming out in AHA, they are recommending diets consisting of more plant protein than animal protein. They haven't convincingly provided evidence to show the vegetarian diet is better. If you have been asked to be, or if you have been placed on a vegetarian diet from your healthcare provider, you now need to have a conversation with your doctor about if you need to take any additional supplements, whether they are vitamins or other supplements, whether it is strictly vegetarian, whether you're allowed to have things like fish and other products, but not meat. And how has your cholesterol responded? Because quite often, I am guilty of this as well, and there is physician inertia. You start someone on a diet, and you really want it to work because you don't want to start medication. Contrary to popular belief, doctors don't like to start medication either, but it's not working. And if you have to be honest, if it's not working and your cholesterol is not budging, and I can tell you that once your cholesterol is going above a certain level, especially if you're over a certain age, this usually requires medication, and dietary changes alone are not going to work. So it's a good thing that you started that first step in adopting a healthier diet, which I'm not going to say is being vegetarian, but a healthier diet. The next step will be to monitor your cholesterol and then have a discussion with your healthcare provider about whether you require any additional supplements because you might be at risk for other things from not eating meat. I see a question in the chat. Chair, am I allowed to read the questions out from the chat, or are you reading them?
No, you can go ahead, but you can go ahead.
No, you go ahead. You have a question.
Yes. The chart, they said I'm hypertensive for over 20 years and diagnosed with diabetes from 2020. My HbA1c A1C at that time was 6.5 mmol. I don't know the term, but I've
Minimal,
been,
yeah, those are just the units. So 6.5.
Okay.
And
Yeah.
I've been on intermittent
fasting
fasting
for a while. Yeah.
Yeah. So although the evidence for intermittent fasting has not been published as yet, I suspect that it probably will be sometime next year, or hopefully early next year. There is a evolving conversation about intermittent fasting and weight loss. We just don't know, for instance, how effective it is at keeping weight off, but we certainly have evidence that it works. So people do lose weight. Now, there's also a question, is there danger with rapid weight loss as well? Or should weight loss be occurring at a certain rate? Because remember, obesity or excessive weight is not just fat that's there, just lying there dormantly. Fat is a metabolically active organ as well. And there are some obesity specialists who believe that you shouldn't have this rapid weight loss because other problems occur in the cardiovascular system from rapid weight loss as well. Now, when I say rapid, I don't mean that, I can only lose 2 pounds a year because if not, it's too much stress on my heart. But you really should be, if you're going to embark on a intermittent fasting diet, it should be under the observation of your doctor, especially if you have diabetes and hypertension. And I suspect that your healthcare provider will want to monitor some blood tests more often than they probably would have if you weren't on intermittent fasting. You may also need adjustments in insulin and medication, oral medication for diabetes, based on the times that you're fasting. Okay, it's important to distinguish vegetarian and vegan diet generally, which can include ultra-processed snacks and a lot of unhealthy items, versus whole foods, plant-based lifestyle, which has extensive supporting evidence and documented results. And it's actually the diet that is recommended by the AHA, which I showed on a previous slide, which again, as I said, you can only eat the healthy foods if they are accessible. And if not just accessible as in the country or on the supermarket shelves, but you have to be able to afford them to consume them. Patients often say to me, it's all right, you are going on television talking all these things about eating healthy. If I have to kind of balance a budget where I have to buy healthy foods, which is a perception that they're a lot more expensive, I have to buy school clothes for kids going back to school, and I have to do all these other things, including paying an outstanding balance on a water bill. So those are things that you have to negotiate. So sometimes I think we are too hard on patients with this kind of just eat healthy, do whatever. And I think possibly a better thing might be to suggest to them, all right, so here are the really bad things that you should cut out. All right. No, you do not have to have sunshine snack corn curls every day, regardless of how cheap they are. You can convert that into something else that's healthier, even as a snack, right? So those kind of practical conversations, rather than just sending them to the supermarket and saying, just eat healthily, end of story. Deborah King's hand.
Deborah has a question. Deborah, go
Good
ahead.
evening. Good evening, everybody. Dr. Kenneth, so whose responsibility is it? I've just recovered from COVID. You've just given me all this exciting numerical data about the impact of COVID on the heart. How am I supposed to know that? Well, should I go to the doctor and, have them listen to my heart? Should I be concerned? Those are the type of questions that are going on in my head, unless I am hypertensive or diabetic or have a previous heart condition.
Sure. Thank you very much. And so that's a very good question. Who is responsible? Because certainly as a patient, you can't be out there at home thinking, you know what, I should just go and just get everything checked out, right? Because I just did this presentation, I had COVID. How do I know if I even have the symptoms to be alarmed at? The answer is, it's not just the patient's responsibility. Remember I started off by saying the controversial political determinants of health. So the Ministry of Health, for instance, has a responsibility of making this public knowledge and encouraging people, if they have these symptoms after an X period of time, that X seems to be around 4 to 6 weeks, your body should return to pre-COVID. If you're having these annoying symptoms, you shouldn't ignore them. We should not be forgetting stuff just because you're post-COVID 2 months into it. Or you shouldn't be feeling so fatigued that you can't get through a full day's work and just racking it up kind of to, oh, it's just the COVID. Your heart shouldn't be suddenly racing during the day for no apparent reason. So what I would answer you by saying is, there is a larger systems responsibility, which I alluded to. We should be even monitoring these things. Long COVID should be a reportable condition, such as type 2 diabetes, which is reportable. But patients should also kind of be aware through public education, which is again coming from the health service. These are the symptoms to look out for. So for someone like yourself who is post-COVID, if you are experiencing symptoms such as excessive shortness of breath, or if you are feeling very fatigued, or if you are finding that your memory is not what it used to be, or if you notice any other abnormal findings like tingling in the fingers or toes, or that your diabetes control hasn't returned to normal, your blood pressure control hasn't returned to normal if you were before, this is not something to take lightly. It is, you should be assessed by your doctor. What do I do when I get into the doctor's office? Say, well, look, this is now 2 months or 3 months post-COVID, and my blood sugar hasn't come down below 7.4 since then. Or I can't get through half the day at UB without stopping and sitting down. I'm so exhausted. I've had to stop the gym because I can't continue. These are early warning signs. You would be surprised how many patients, and I know that there are colleagues on this line, who come with these very mild symptoms. I saw a young man recently who is a gym instructor, so I assume he's fit. And he just said, I can't exercise with my clients anymore. And, is this normal? And I said to him, of course not. You've had COVID about 4 months ago. And he has changes on his echocardiogram, which is an ultrasound of the heart, which is probably COVID related because he was a young fit guy before and these changes have occurred. But the point is, have these conversations with your doctor. Don't kind of keep it at home in a diary and think, this is going to go away eventually. So the takeaway point from this presentation, if nothing else, if you've had COVID-19 and you're still experiencing symptoms relating to the disease or even new symptoms more than 6 weeks after you recover from the infectious stage, you should discuss this with your healthcare worker.
Thank you.
I'm looking for any other hands. Okay, so truly wholesome foods are God's gifts to humanity. Example, abundance of fresh local fruits and herbs in season, and they cost zero. Well, I don't know, some pretty larceny thing might come in there. But whatever happened to the great Caribbean traditions of every household growing some foods and having fruit trees, and everyone shares something. You're talking back to what the previous principle described as the village culture, and whether the village culture still exists and whether we are really our neighbor's keeper. I think, to be fair, we have become a lot more industrialized. So for instance, the household everyone is leaving for work in the morning. No one has time to take care of fruit trees and to be planted and those kind of things. And I get that. Could we do a lot more? We probably could do a little bit more. Certainly, COVID taught us, if all the lockdown, that a kitchen garden is not something to be allergic to. But you're absolutely right. Perhaps the thing that our grandparents and even our parents might have had on us is that they kind of took this healthy eating out of necessity more seriously, and they actually had their food prepared at home. Dr. Connell, have you found that there is a link between long COVID-19 symptoms and other chronic diseases? I'm going to insert the other. The answer to that is yes. Now, we're not quite sure how this long COVID, in fact, we no longer even call it long COVID, the post-acute sequelae of SARS-CoV-2, or past syndrome. We're not exactly sure what causes the phenomenon, but we know that it happens. And it is thought, and this isn't completely new for a virus, by the way, that this virus can do two things. It can destroy the organs as any other virus can during the actual infection. So that's easy to kind of figure out. You get an infection, you get, your heart may be damaged, like the inflammation, and it may not recover, or your blood vessels may be damaged, and that sets up a whole cascade for cardiovascular risk. But what it seems might also be occurring more importantly, especially with the newer variants, because the virus is not stupid. It's quite clever. It has designed itself so that it almost corrupts your immune system, and that this corrupted immune system now has a challenge in differentiating what's you from what's not you. And for instance, it may start to attack a pretty good kidney that's just there innocently bystanding in your body because it doesn't recognize it, or it recognizes some abnormality. And so the immunoregulation that occurs post-COVID seems to be very important. This is why I say that we may not have seen the worst of COVID, but don't see the pandemic as just these infectious waves. We now have to look back or maybe look forward in 10, 20 years and then see what has this impact. Are we now seeing more people with unexplained stroke? This is already happening in the United States. There is a high uptick in stroke, not really explained by traditional NCDs. Are we seeing more patients with heart failure post-COVID? Those kind of things. So we will never know the true impact of COVID-19 until maybe 10, 20 years from now when these things start to be unmasked. What can you do today? You need to now stay on top of those things you can control. You can't control the future. So you have to be obsessive about your healthy diet, obsessive about exercise and maintain a healthy weight. Obsessive about controlling your blood pressure. If you are hypertensive, now is not a good time to say, 5 millimeters above target is not going to kill you. Yes, it will kill you. It may not kill you immediately, but over time, your risk is going to increase. So you need to be obsessive about those things. And I'm trying to scan the chat to continue. I'm seeing things about breadfruit tree, mango tree products. Anyone who has a question to ask, you can feel free to unmute your mic as well. Jacqueline Griffith. Okay, maybe that was not an intentional unmuting. Jacqueline, if you're speaking, we cannot hear you. Okay.
Jacqueline?
I thought she was trying to say something there, but okay.
Someone said, Dr. Connell, that they had blood work and they recognized that they had low vitamin levels within the blood. If you can explain that.
Yeah, low vitamin D levels. Now, this is a big controversy in medicine currently. I'm curious as to what your doctor is going to tell you, whether it should be treated or it shouldn't be treated and how it should be treated. But again, I'm not going to say it here in open forum, but this is a discussion you should have with your doctor and not just go out there and buy a whole set of vitamin D supplements and start taking them. So a low vitamin D, how low, in what setting, those kind of things are questions that you should definitely have with your doctor before starting replacement. Now, to my knowledge, there hasn't been a link, although we haven't really explored everything with COVID, with low vitamin D and COVID-19, although it is a chronic infectious disease, might be associated with low vitamin D. There hasn't been a clear association, in my knowledge, with vitamin D and post-COVID or even COVID.
I have a
question.
Yeah.
Sure, Deborah, go ahead.
Yes, I'm just curious. How much information are the doctors at the QEH collecting when you look at what's happening in America and those countries? Or are you working alongside your colleagues there? Passing information. Are you doing that sort of thing?
Right. So let me now wear my university hat. And I'm going to say that, to my knowledge, there's insufficient information being collected about the post-COVID data that we need. Mm-hmm. Now, the hospital, interestingly enough, is not an institution that normally collects or manages this kind of, to be fair to them, they would kind of just outsource it to a university. Mm. But again, that has to come with the permission of the Ministry of Health and Wellness. And then that has to come with almost a question in your mind that I want to know this information because it's important. And I don't think we've reached that point as yet. So we've now, and I'm being very serious, we've now gotten past the whole, people aren't dropping down dead from COVID, although people are dropping down dead from COVID, right? But it's not as severe a pandemic as we saw before. Yes. So remove the masks, remove the travel restrictions, remove everything. Let's just get back to normal. Whereas what we should have done, which some countries are doing, was, well, hang on, something else is coming here that isn't quite an infectious disease pandemic, but they now have long COVID clinics. There's no national health data collection. All right. Mm. The President of the United States has just approved another $1 billion to the National Institute of Health to study the post-acute sequelae of COVID-19, because America almost knows this is a tide this is a tsunami that's coming to their health system, that's already shut post-COVID. So in direct response to your question, unless I am proven wrong, and I hope I am, there's no data looking at that being collected currently. But yes, absolutely, there should be. And we should be kind of pushing our ministry and our institutions, and even quite frankly, our university, putting pressure on us to interrogate this data and collect it. Because think about it. I mentioned an uptick of heart failure, and this is anecdotally, which is the lowest level of evidence, right? When I was on service in the hospital only recently, heart failure is the number one, what we call revolving door diagnosis. So the patients come in heart failure, they get right out, we remove fluid, they go back out, they come back in, they go back in, and this kind of revolves over and over. So what happens to you now, coming there, if you're a genuine emergency, not that they're not an emergency, is that you can't get into the emergency room because it's blocked with frequent flyers. And why are there frequent flyers? Because perhaps the health system hasn't been reconstructed to manage whatever is driving the frequent flying. Like, for instance, are they at home? Should we have community projects to manage heart failure before they make it to the emergency room? Should we be checking on them remotely to find out that their weight is increasing with fluid retention and kind of giving them information on the telephone to prevent? These are things that happen in other countries, right? So my thoughts on this is that as a nation, we need to seriously consider the approaching tsunami of long COVID, because our health system really is vulnerable to it. We don't have a Harrison point to treat this. We wish we did, but we don't. We have the same health system we had pre-COVID, which was already struggling. So we know that that's a recipe for not a good outcome. Does that answer your question?
Yes, it does.
And it scares you, right?
It's scary.
It scares me as well.
Thank you.
You're welcome. Dr.
Another
Connell,
question? We're gonna take one more question.
Sure.
Any other questions, please? I haven't seen anyone.
Can I say that I see Deborah has her camera on. Deborah is the reason I am in medicine, because it was horrible at mathematics. And so I said, well, what can I do in university that doesn't really involve a lot of math? But thank you so much. She was an excellent teacher, and I really thoroughly enjoyed mathematics at Lodge School in those days.
Okay. Any other questions, colleagues, before I ask Deborah to give the closing remarks? Okay, Dr. Connelly, this seems not to be any more questions. So I will now call on Deborah to give the closing remarks. Over to you, Deborah.
Thank you, Natasha. Let me just say, before seeing this topic, it was nothing in my head at all, nothing of concern, nothing to think about. But I'm glad that I was here to hear and see, the visible evidence. So on behalf of the Education Committee of the UWI Hill Co-operative Credit Union Limited, I graciously convey to you our appreciation for agreeing to facilitate and present the topic COVID-19, heart health, and a new NCD risk. Dr. Connell, you have shared with us your expert knowledge on the subject and have made us wiser for the sum of it. You've made us aware of the impact of COVID-19 on hypertension, cardiovascular disease, diabetes, the impact on our healthcare system, the impact, general overall. Nothing has escaped the occurrence of this pandemic. And we are wiser now that we can pass on to our friends and to our families information on which they can act on, myself, prudently. I wish you the best in your future endeavors, and we're happy that you have consented to partner with us in putting on such an activity. I also want to say that you have nudged us in the back by making suggestions as to what we can do as a credit union to help our members, and by extension, their family and friends, more healthy or to adopt a more healthy lifestyle. And I'm sure that we will take up the challenge. So to you, Dr. Connell, I say thank you. And I did not know that today was Heart Day. Heart
Yes.
Day. I didn't know today was Heart Day, but I did have to say to you again, Dr. Connell, a hearty thank you. And we are proud of you, and I'm proud of you as well. Thank you very
so
much.
much. And
I
to
also
everyone, remember to check out Life's Essential 8. You can Google it online,
Yes.
and you have the packages.
Right. Heart, that is heart.org. Heart.org, yes?
Yes.
Heart.org.
Mhm.
And I also want to say to the members who are here this evening, thank you for being a part of the exercise.
Thank you.
Thank you, Deborah. Thank you very much, Dr. Connell. And I can see that we have quite a few positive feedback. A number of persons said it was very informative, interesting. Yeah, so thanks again.
Thank you.
Yeah, for delivering this presentation. And also thank you, members, for attending. Our next seminar will be next month. So I'm looking forward just to see you there as well. We're gonna send out the notice, like in this case. So just look out for the date for our next seminar. It's gonna be via Zoom as well. So thank you very much again for attending.
Have a good evening.
Good evening, everyone.
Okay, good evening.
Good evening.
Night night.
Good night.
Good night.